Your patient just pressed the call light. They're having chest pain. Your heart starts racing too. Is this it? Is it a heart attack or something else entirely? Knowing the difference is critical, and making the right call can save a life. In the next few minutes, I'm going to walk you through exactly how to tell the difference between cardiac and non-cardiac chest pain, and when you absolutely need to call that provider, stat. First, let's talk red flags. True cardiac pain isn't just pain. Your patient will describe it as pressure, heaviness, or a squeezing sensation, like an elephant sitting on their chest. A key sign is radiation. Ask them if the feeling travels to their jaw, neck, back, or down their arm, especially the left one. This pain is often triggered by exertion and gets better with rest. Watch for those other scary symptoms: nausea, sudden sweating, shortness of breath, and a sense of impending doom. If you see a patient clutching their chest, pale and sweaty, that's a major cardiac red flag. It's very different from a patient who can point to one specific spot and say, "It hurts right here when I press on it." Next, you need to become a detective and scan that chart for clues. What are their risk factors? A history of a prior heart attack, stents, or bypass surgery is a massive clue. But you also need to look for other conditions. I use the mnemonic SHOCKED to remember them. Smoking, hypertension, obesity, CAD history, that's coronary artery disease, kidney disease, elevated cholesterol, and diabetes. The more of these your patient has, the higher your suspicion for a cardiac event should be. These factors, combined with the symptoms we just discussed, paint a very clear picture. Now, not all chest pain is a heart attack. There are many mimics, and your assessment skills are crucial here. Let's run through the most common non-cardiac causes. If the pain is a burning sensation that gets worse after they eat or when they lie down, think GI, like acid reflux. If it's a sudden, sharp, pleuritic pain that worsens with a deep breath, you should consider a pulmonary cause, like a pulmonary embolism or pneumonia. A big one is musculoskeletal pain. If you can press on their chest wall and reproduce the exact pain they're feeling, it's very likely costochondritis and not their heart. We call this poking the pain. If it's reproducible, it's usually not ischemic. Also, consider anxiety or a panic attack, which can cause palpitations and chest tightness. And don't forget other zebras like shingles, which follows a nerve path, or the dreaded aortic dissection, which patients describe as a sudden, tearing pain that radiates straight to their back. So, you've done your assessment, and you're worried. What do you do next? First, get a full set of vital signs immediately. If the pain sounds cardiac, that pressure-like radiating pain with sweating or nausea, do not wait. Call the provider stat and clearly state your concern. Your next sentence should be, "I'm requesting a stat EKG." That EKG needs to be done within 10 minutes of a patient's complaint. While you're waiting, be prepared to give nitroglycerin, but hold it if their systolic blood pressure is below 90 or if they've recently taken drugs like sildenafil. And remember, document everything. When the pain started, what it felt like, what you did, and how the patient responded. Your notes are a critical part of the medical record. Remember, as nurses, we are the first line of defense in catching a true cardiac event. Knowing these red flags, recognizing the risk factors, and acting fast is what makes the difference. Escalating quickly and getting that EKG within 10 minutes could be the single most important thing you do on your shift. You've got this. Let us teach each other. If this video helped you feel more confident, drop a comment below and tell me about the trickiest chest pain case you've ever seen at the bedside. And don't forget to like and subscribe for more clinical breakdowns made just for nurses. Thanks for watching and for supporting my channel. Take care.